All right, well, we can get started, I think. Welcome, everyone. My name is Bobby Symes, and I am the Director of Healthy Aging here at United Way BC. And I just wanted to take the time to welcome everyone for joining us here today. We are so excited to have you come and join and celebrate Social Prescribing Day alongside of us. Today is a great opportunity where we bring together community, healthcare professionals, organizations, all to highlight the power of social prescribing and its impact on health and well-being. Social prescribing is all about connecting individuals with non-medical resources and supports in the community. It's a powerful tool for addressing the wider social, emotional, and mental health challenges people are facing. And it's something that has truly gained momentum throughout the recent years. So today, as we celebrate Social Prescribing Day, it's a day to come together, learn, and celebrate the positive change that social prescribing is fostering in communities across the world. We hope to leave you today feeling inspired, empowered to continue supporting this movement. Before we begin, I'd like to take a moment to acknowledge that we're all joining today's webinar from various places and spaces. Today, I join you from the ancestral and unceded homelands of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. We feel indebted to them for caring for this land. Social connection has always been at the heart of Indigenous people. For thousands of years, Indigenous communities have embraced interconnectedness, supporting each other, sharing knowledge, and nurturing relationships that help foster holistic health and balance. This deep-rooted sense of community, care, and mutual support is foundational in the practice of social prescribing, where connecting individuals to non-medical resources and support is key to improving health and well-being. Today, as we explore the benefits of social prescribing, we are reminded that at the heart of this approach is community connection, a value shared by Indigenous people and one that continues to inspire the way we care for each other in today's world. I'd like to express gratitude for the opportunity to be here today and for the wisdom and strength of the Indigenous people whose lands we are on. May we all be inspired to strengthen our own connections, support one another, and foster a sense of belonging. So just a couple of housekeeping notes as we get started. Everyone that is participating is muted. We are wanting everybody to feel free to introduce yourself, maybe where you're tapping in from today, tell us where you're joining from, include your name, your organization, your pronouns. You can also turn on closed captioning if you haven't done that already using the CC feature in the toolbar at the bottom of your screen. Today, we will have a brief question period at the end. You can use the Q&A feature, which is also located at the bottom of your screen. And of course, this webinar is being recorded and it will be posted and shared along with the slides on the Healthy Aging Core platform. So before we dive into the sessions, I'd like to take a moment to thank our amazing speakers who've joined us today. They bring with them a wealth of knowledge and insight, and we're lucky to hear from them. Today, we have Dr. Kiffer Card, who's an assistant professor with the Faculty of Health Sciences at Simon Fraser University, who received his training as a behavioral epidemiologist, social ecologist, and health services researcher at Brigham Young University, as well as Simon Fraser University, where he got his PhD, and the University of Victoria, where he did his postdoc training. Dr. Card is the recipient of multiple highly prestigious awards, including the 2025 Blanche and Charlie Beckerman Public Health Innovation Scholar Award. Over the past 6 years, Kiffer's work has been featured in more than 200 publications and over 100 presentations. Kiffer's rich research program provides training to future scholars, raises awareness of key social reforms and policies that aim to help Canadian leaders build happier and healthier communities. Kiffer will speak to us today on what is needed to promote the uptake and implementation of social prescribing. I also want to welcome Safiya Clarke-Mendes, who is the Education and Learning Specialist at the Canadian Institute for Social Prescribing, located at the Canadian Red Cross. Safiya is a Master of Public Health graduate and has experience working in health promotion and research across public and private sectors in Canada and the Caribbean. At CIS, Safiya works collaboratively with social prescribing partners and stakeholders across the country in the design and development of educational and training resources that support capacity building for the growing social prescribing workforce. Safiya will share with us today the results from the Social Prescribing Training Needs, Opportunities in Canada survey. So without further ado, let's get started. I'm thrilled to be with you today as we embark on the journey of discovery, collaboration, and celebration during Social Prescribing Day. Kiffer, over to you.
Great, thank you. I'll go ahead and pop my slides up to share with you. It's a wonderful opportunity to be here with all of you. I think to some extent, I understand, or at least assume, that I'm speaking largely to a crowd of the converted, people who really understand the importance of our social connections and our relationships to shaping and influencing our health and well-being, something that I think, as Bobby mentioned, traditional Indigenous communities, not only here in North America, but across the globe, have recognized since time immemorial, but has been lost largely from our practice and how we organize ourselves as communities and within our healthcare systems. But for those of you who don't know what social prescribing is really acknowledging this, that 80% of health outcomes that shape your well-being, your quality of life, your happiness, your health, about 80% of that is all related to non-medical or non-clinical determinants of health. That means that everything that happens in the exam room, in the hospital, in the emergency room, only explains about 20% of the variation in how long you live and how healthy you are. And the remaining 80% has nothing to do with the medical system. It has to do with the communities we live in and the health promoting ways in which those communities enable us to meet our basic human needs, one of which is social connection. So social prescribing is really built on that acknowledgement that people need a holistic approach to healthcare that connects people to those non-medical needs, particularly when, due to discrimination and oppression, they've lost connection with those kind of fundamental natural supports in their lives. Social prescribing, for many of you know that it really got its starts in the United Kingdom and has really flourished there with a government who developed a loneliness strategy and has since put significant investments of funding into allowing the primary care networks there to form and recruit people as community navigators or link workers, which are kind of key to the social prescribing process. Here in Canada, pilots have been undertaken across Canada, many being funded by private philanthropic organizations. And some here, like our BC United Way programs, are actually funded by government, recognizing that this really does have strong potential to improve people's health and well-being. And the evidence isn't just anecdotal. We see consistently that people who are engaged in this high quality personalized care and get the resources and supports they need are able to build capacity, self-efficacy, take control of their healthcare, and be embedded in warm communities where they can have their social and emotional and health needs met. So our research wasn't so much to undertake to understand, is social prescribing effective? Certainly, we need ongoing evaluations of the social prescribing programs that are going on. But this initial step in our research process was to understand from the perspectives of patients and providers what is needed to promote the uptake of social prescribing. Because oftentimes, when we talk about a program as exciting as social prescribing, it often gets lost in that conversation of actually how hard it is to really change a healthcare system and fundamentally reorient it to meeting those basic needs through a new program. And so we recruited and had focus group interviews with patients and healthcare and social care providers, and we really asked them to help us understand what they perceived as the fundamental barriers to social prescribing implementation, and to also help us identify and think through what resources we could start helping to develop and what resources we could point our partners to develop as well. At the Canadian Alliance for Social Connection and Health, we don't play direct service roles. We support organizations and networks and our network to have the information, knowledge, and resources that they need to do that sort of frontline work. And so the resource needs that we identified explored what sort of training people need, what supports they needed around screening and educating patients about the importance of social connection, supports for linking patients to appropriate services and following up with those patients to make sure that the services are meeting their needs. And so I won't go into all of our results. Certainly, I'll kind of give you an oversight. The report pictured here, which I think there's a link to in the chat, this research report details these findings in depth. And so if you need a resource document to refer to support your initiative to kind of develop out a resource or to find some of the resources that we identified through this process, check out the full report there. But our first objective to really understand those perceived barriers and facilitators to what made social prescribing programs work when implemented. We really kind of developed this kind of 3-point triangle as a framework for understanding what makes a social prescribing program effective. The first was really around issues of accessibility, right? If people don't find that they can access the social prescriptions themselves, or the social prescriber, or the link worker, community navigator, that really seemed to be a big difficulty. Chief among the factors that really influenced accessibility was whether or not there's even services available in a person's region, whether or not they had the transportation or financial resources necessary to access those, whether there were hours of operation that were good fit. And then a lot of it was just personal preference. Did they feel comfortable doing something in person or accessing an online directory? Or did it meet something they were interested in? Prescribing somebody to a sports program when they're not really all that interested in sports, for example, wouldn't be a good personal fit. And chief among the identified facilitators was really having interactive maps and directories, ride sharing, and other sort of resources that were accessible not only to the community navigators or link workers or community connectors, but also to the patients themselves who wanted to take that on themselves. The second component that we kind of identified was this process efficiency. Really based in, is there organizational readiness to coordinate care, to empower patients to have autonomy and shared decision-making in their own care. And really the factor that seemed to be most important in shaping the process efficiency was the availability and access to a dedicated link worker who was integrated into the patient's care team, meaning they were working hand in hand with the prescriber or other members of a healthcare team, like a nurse practitioner or a physician or a nurse or social worker, and really making sure that that link worker could be a warm handoff and could also facilitate the connections into community itself. So that's been considered kind of a core component of social prescribing, though some social prescribing programs use more pathway-based referrals that don't necessarily involve a specific link worker. And then the kind of third element that we identified as a perceived barrier was just the incredible variation in individuals' needs and interests. I think social prescribing is one of these really interesting interventions because the goal is not necessarily to connect somebody to have them undergo just a program or an intervention. Like an anti-smoking intervention has a very set protocol on what you're going to put somebody through. And that's very easy to evaluate because everybody does the same protocol and the same protocol is supposed to work for everyone. But when you're thinking about people's community care, their culture, their diversity, and how much they fit within a community, that's really going to be contingent on who they are as individuals. And so this has been highlighted as a really important component that you actually need a program that fits. That means what one person might be referred to would be very different than what another person might be referred to. There's not necessarily a universal fit. And so acknowledging that, making sure that people are being connected with the right programs is really core to the effectiveness of social prescribing. Now, in terms of the individual resources, as I mentioned, I won't list them all, but I think that one of the things we were excited to see is how much great work is already available out there around orienting and providing resources for social prescribing. So a lot of the issues isn't that people identified the absence of thing. It might have just been that they didn't know about the available resources. And so I think that's important to just take in context as I go through these sort of things about what the identified gaps were. Because just because something was identified as a gap by a patient doesn't mean that that was actually a gap. It might just be something where we haven't invested enough in making sure everybody knows what resources in our sector are available to them. But the very first component was training needs. People recognize the need that healthcare providers need to be trained in the social prescribing process, that community navigators need the sort of skills and abilities in motivational interviewing and patient-oriented care, and compassionate and emotional regulation. All of those components are things that people need to be trained in, and Safiya will share a lot about work in that kind of regard. And then also training for community organizations. People acknowledge that just because a community organization exists doesn't mean it's necessarily ready to receive patients in that sort of way. And then, of course, educating patients themselves. Not everybody understands the importance of social connection and community participation. Not everyone has the motive or self-efficacy or ability to go out and get connected to the community resources. And so helping patients build those capacities through education and other means was also identified as an important gap. And again, there's resources that have been developed to help meet those things. One of the case study for resources that we wanted to highlight is our recently launched Canadian Social Connection Guidelines as an educational tool, not only for patients, but also for professionals. For those of you who haven't heard about the Canadian Social Connection Guidelines, they're like food and nutrition and exercise guidelines, in that they aim to provide people with an understanding of how they can improve their social well-being and health. The guidelines that we developed are really simple 6 guidelines targeted towards individuals, things like investing in getting enough social connection, helping people maintain and deepen their relationships, seeking out face-to-face interactions with technology. And then to support individuals in uptaking these guidelines, we also developed community guidelines that emphasize the importance of the built environment and how we design our communities, our policies, and making sure that social connection is considered in policy development and design, and the need to measure and make progress. So we also had 6 guidelines for community development. And again, this is a resource that is available to help educate patients about what they can do to improve their social health, but also as a policy advocacy tool to make sure that we know what we're doing as a society and as communities to build healthy and happy communities. Each guideline not only has our core recommendation, but we provide a rationale and additional considerations. So if you haven't visited socialconnectionguidelines.org, please do. There's tons of case studies and resources available. We provide links to many of the resources that were identified through this process, but also through other means of helping people connect with the resources that would help them undertake each of our 12 guidelines. We also provide an assessment, a range of resources with the guidelines, including case studies on how they're implemented, research that supports that guideline, and an overall assessment of our quality of the evidence. So as a case study for a specific tool, I think this is just one of many tools out there that people can be connected to. We can start to think about how we can integrate these tools into how we train and deliver and implement social prescribing processes. The next issue that was identified was around screening of patients. So better screening tools and conversations with providers. People talked about the difficulty of tracking and monitoring or managing self-referrals. And, so this was an important gap that needed to be addressed, making sure that we have good processes set up for this. Same with linking patients to patients. People identified that, that system-initiated follow-up is kind of necessary as part of the linkage process, and identified a number of existing kind of referral pathways that allow people to become linked with the programs that they're interested in. Of course, in order to link somebody, you have to actually identify the service in first. And in this conversation, we really heard about the difficulty of people understanding, unless you really had a community navigator who was familiar with every single specific service that they're referring people to, it became really hard for people to identify the services that would be good for themselves or for somebody who they're providing connection services for. And so really making sure that we're thinking of creative ways, including the use of AI, including the use of patient reports, about what these various services are like was identified as something that the system could help address. And then, as I mentioned kind of a little bit earlier, was this follow-up. A lot of conversations dealt with the fact that, there's privacy issues, of course, around people's health data. But if you're really going to integrate the community connectors and the patients into their shared care decision-making as part of the care team, there needed to be a way for communities and healthcare providers to really have a real connection that made sure that the services that we're connecting people to were effective. And so really this report, I'll just highlight, was really intended to build and help us take those initial steps and think about what is the ecosystem that's needed for social prescribing, and making sure that as we go out and develop social prescribing programs, that we just don't assume it's an easy to do intervention. It's a cheap, it's not necessarily those things. It is certainly an effective intervention that we want to pursue in revolutionizing our health care system. But it really does require this sort of careful attention to the social prescribing process, and making sure that the ecosystem we're creating together here in BC or elsewhere nationally in your local communities is actually filling these various gaps in resources. And so if any of this rang true for you, make sure to check out our report and see all the resources that we were able to crowdsource that met some of these gaps. And so with that, I'll turn the time back to Bobby or to Safiya, who has a great case study on the specific examples here.
Thank you so much, Kiffer. And I think, Safiya, we can go directly to you.
Great, thanks so much. And thanks so much, Kiffer. That was an awesome presentation. And I echo Kiffer. I really encourage folks to check out the report. It's a lot of amazing information. So today I will be presenting on the social prescribing training needs and opportunities in Canada report. So for folks who may not know, I'll just tell you very quickly a little bit about the Canadian Institute for Social Prescribing. We are a national collaborative that works with partners and communities across Canada and around the world to connect people and practices, to build knowledge and evidence, and influence policies, all with the goal of strengthening health and community care systems. And as a part of my work, I collaborate with partners across Canada to understand what currently exists to support workforce development and the gaps in education and training. As Kiffer so well explained, social prescribing initiatives are expanding across the country, and there is an emerging need for robust training and support for this growing workforce that reflects not only what is required for consistent and cohesive service delivery across the country, but also what will allow for adaptability and context-specific care, and particularly training for connectors and navigators. Part of our work at CISP is identifying those opportunities while supporting the many ongoing efforts in training development across regions, as Kiffer shared a lot of really amazing resources that are currently being developed, that are currently available. We work to support and amplify those great efforts. Sorry. To this end, in 2024, we at CISP held 2 consultations with social prescribing partners in collaboration with Sean Brand, who is a UK-based consultant with the Social Prescribing Network. The purpose of these consultations was initially to explore the opportunities and benefits of a social prescribing connector workforce guide and an associated competency framework. And both of these resources exist in the National Health System in England, to which Sean Brand contributed. So to explore these ideas, we convened a virtual workshop with social prescribing practitioners, which included healthcare providers, program managers, and administrators, as well as connectors, to get feedback on core competencies for the connector role, as well as knowledge required to deliver safe and effective social prescribing. We then followed up with a survey with a broader group of practitioners to seek further feedback and to gain some insight on what is available by way of social prescribing training in Canada, and to identify gaps and priorities for training and supervision and support for the connector role. So we got feedback from 27 participants across 24 organizations in 6 provinces. And so you can see that the report reflects findings from a small group of early adopters, but it does provide very valuable considerations and insight for future work in strengthening the social prescribing workforce. We analyze the findings by insights on the connector role and insights on national and provincial training. And I'll start by discussing the insights on the connector role. We started with the identity of the social prescribing connector, and what responses revealed is that there's a range of names by which the connector role is identified. Of course, there is the term linked worker, which was popularized in the UK and is used in some regions in Canada. But other titles that are commonly used include active words such as connector and navigator, and some would often include a community along with these terms. But regardless of title, all of the responses emphasize the importance of role clarity among all stakeholders involved in the delivery and in the delivery of the social prescribing pathway. So sorry, my computer is freezing a little bit. Okay. We also asked folks to share feedback on core competencies for the social prescribing connector. We drafted these competencies prior to the initial virtual work consultation, and the competencies were developed based on global desk research, as well as informed by available information on the connector role in Canada. They were then refined prior to distributing the survey. And so in the survey, participants were asked to share their thoughts and feedback on these refined core competencies. And it was found that participants widely agreed that the connector's competencies include broadly competency domains that fall under these three key categories. So competencies that support the individual, those which enable the connector to engage with the community and support community development, and competencies that support program administration, and particularly data collection and monitoring and population health monitoring, in order to best understand how the program is supporting community needs and how it can be adapted to better support community needs. It was recognized that the role of the connector varies across the country and has to be adapted to local contexts. And so the competencies and skills building efforts may be prioritized. Some competencies and skills may be prioritized over others, depending on the community's needs and the local context. That said, participants did identify some top training priorities. You can see on the right that the connector roles should broadly have, which include interpersonal skills, cultural safety and competence, community systems and resource knowledge, and safety and self-care in order to prevent burnout and support overall well-being. We also asked participants to share about existing mechanisms and strategies for supervision and support of the connector role. Responses indicated that there's currently a lack of consistent, formalized and regular supervision strategies for connectors. And it was found in this group that supervision typically happens more on an ad hoc basis. And so we asked participants to reflect on the types of essential support and supervision that connectors would need. And these were the major themes that we found on the left. So first, clarity on the connector role and the job scope, as well as autonomy in their practice and recognition for their contributions to the team and larger community, as well as comprehensive training and access to resources, including assessment and training tools. And I think that this also corroborates some of Kiffer and his team's findings. Regular and consistent supervision based on respectful and trusting relationships with supervisors was emphasized as very important. Supervision that involves feedback, case debriefs, support for problem solving and workload management. Folks talked a lot about the need for support for self-reflection on the part of the connector role, as well as support from supervisors for emotional strategies for emotional well-being in order to prevent burnout. Participants also talked about clear safety protocols for practice, particularly for connectors that are working with clients who are managing complex or high-risk health needs or health and social needs. And finally, opportunities for collaboration and connection with wider interdisciplinary teams. So we know that as social prescribing models and delivery are at various stages of development, and the responses to our survey shed light on the variation in the availability and comprehensiveness of training for connectors and broader ecosystems across regions in Canada. These are some of the notable training and resources that were shared by survey participants, which Kiffer also shared in their report. And these were some of the resources that our respondents that we found our respondents use in their own teams, and that connectors have used to build their own capacity to deliver social prescribing. But to further explore opportunities for training development, we asked participants to prioritize 11 training opportunities, which we had initially identified in the virtual consultation. The table on the left depicts the training priorities from highest to lowest, as well as participants' perspectives on whether the training should be delivered nationally, regionally, or nationally with regional adaptations. And so you can see for most of the topics, participants identified that these trainings should be delivered nationally, but have room for regional adaptability, which emphasizes the importance of a certain level of consistency at a national level with room for regional adaptations to account for local community needs. We also found in this survey, participants shared the importance of knowledge, communication skills, and behaviors of social prescribing program managers and supervisors as very, very important for not only supporting the social prescribing connector role, but also the overall successful delivery of social prescribing initiatives. Participants talked about the need for these practitioners to be trained in and have a very deep understanding of social prescribing models and principles. Also highly prioritized was a deep understanding of the connectors' function on the social prescribing team and their well-being needs. And this was talked about in the context of this knowledge and these skills as being important for social prescribing connector job satisfaction as well as retention. And also prioritized was a deep understanding among managers and supervisors of community resources and skills in partnership building with health providers and local organizations. The workshop consultations and survey provided very valuable insights, but as I mentioned, the number of responses was somewhat limited, and additionally, social prescribing initiatives and practitioners involved have expanded significantly since the survey was conducted. That said, we were able to identify some significant opportunities that we can explore to support Canada's social prescribing workforce. And we believe that these opportunities and the findings from the survey can serve as a great foundation for social prescribing funders, managers, implementers, and practitioners to build on as we continue to explore and invest in opportunities for training and resource development. So these are the overarching opportunities that we found. First, as I mentioned, participants have emphasized the need for clarification of the connector role. Efforts in this area would include further developing our understanding of the backgrounds of social prescribing connectors, including their professional backgrounds or educational backgrounds, as well as taking a deeper dive into the competencies and skills that connectors use in their practices and how these skills and competencies differ depending on their geographical context, the populations they serve, among other variabilities. We also found that there's a need to explore and collaborate to build appropriate and consistent standards for supervision and support of the connector, which would include, as I mentioned, training for supervisors and program managers, and more broadly, the development of support mechanisms for connectors. And this does exist in a lot of ways through communities of practice for connectors and social prescribing practitioners that exist in various regions across the country and organized through local initiatives across regions. And finally, as Kiffer pointed out, there's a variety of available training and resources in Canada, and there are still opportunities to amplify these resources to make sure that folks are aware of them and are able to access them as folks are building their own social prescribing initiatives or just trying to build their internal capacities. There's, of course, also opportunities for us to collaborate and explore how we might develop specialized social prescribing trainings according to the topics that we identified that are broadly applicable, but that are also regionally adaptable. And in exploration of some of these opportunities, these findings have enabled us at CISP to develop a few key resources to support training and education of the social prescribing workforce. The first is the Link Worker Competency Framework. This was created directly from the feedback that we received through these consultations. And it is a resource that outlines the competency domains and expands a little bit on them to give context as to how these competencies are operationalized. This resource aims to be as a starting point to establish clear and consistent standards for practice. The second is the social prescribing training roadmap, which outlines the activities, competencies, and skills for key practitioners involved in social prescribing delivery. So this is a resource that is targeted to the broader social prescribing ecosystem, and it also includes links to available training resources that support specific skills building for each activity. So it's really a navigational tool that can help folks understand what is out there and how they can go about what is required of them in the delivery of social prescribing and how they can go about building those capacities. Thank you all so much for your attention, and thank you to United Way BC for the opportunity to share these findings. And if folks are who are listening in, if you are currently creating any or developing any training resources, or if you're exploring similar ideas, please do reach out. We would love to hear about your work and find ways to collaborate. I'll leave it there.
Thank you so much, Kiffer and Safiya, for your wonderful presentations. Just a reminder that we do have some time for some questions and answers. You can use the Q&A feature right at the bottom of your screen and type in your questions. And Laura is going to help me navigate some of those. But as those questions are starting to come in, I just want to give each of Kiffer and Safiya, just to have a brief response to the question, what immediate actions can community connectors take to advance social prescribing in their practice? Kiffer, you can start.
Yeah, I think that's a great question. I'm a big fan of all baby step approaches. I think people, are operating within their skills and resource constraints. We certainly shouldn't wait for the system. We should be champions in and of ourselves to advance where we're able to, of course. And I think for the community navigator, really starting to build out some of these resources yourself, but doing it in a way that can be preserved and shared beyond you. I think one of the big challenges that I see in social prescribing is the precarity of the link worker and your community connector workforce. And while some areas have really strong investments from government or municipalities or health systems, that's not universally true. And so really thinking about the ways that we can create a lasting legacy for whatever amount of time that we're going to be in a role for, by going out, finding the right organizations, the right things that we could refer people to, and really getting to know those organizations in a way. And some of that might just begin with a phone call, asking for a tour of somebody's facilities, or asking for the ability to drop in and make a visit to a site, and just get that information and then document it in a way that it could be potentially handed off should you move on, or can be made available in more public ways so that people aren't necessarily reliant on you. In that way, I think all of us can play a role in building a sector, and particularly if we can think about how we can crowdsource these sort of things and pull together people's collective knowledge. I'm not a big advocate for doing things just on your own, but thinking about how you can collaborate with a team of people around you to do that. So that's what comes to maybe the top of my head of something you could go out and do this afternoon.
Yeah, I totally agree. I think those are great ways to for connectors to play a role in championing social prescribing in their local communities and in their local sort of community tables. I think when I think about advancing social prescribing from the connector's perspective, I mean, these folks are already playing such an important role in advancing social prescribing just merely by working with individuals and communities in the way they do, connecting people to local resources and advancing well-being in a holistic way is such a strong way of advancing social prescribing in and of itself. I would say for advancing, if we're talking about advancing practice as well, of course, seeing what is out there in terms of what is available by way of training offerings, focusing on the types of competencies that maybe you might need more, that might be more needed in your particular community, depending on the population that you're serving. And then also more on a higher level in terms of advancing social prescribing in your community and nationally. I think where you can, documenting your stories, I think, you know, connectors really are on the front lines of and see very clearly sort of what is needed and how it can be made better. And so where folks can, documenting those in stories and impactful moments in your practice and seeking opportunities to share those experiences, I think is the storytelling aspect is going to be extremely important as we continue the momentum in this work. And I think it's really the storytelling too that's been such a huge part of what's moved this movement forward.
Thank you both. I believe this question is directed to Kiffer. You say we need to educate participants why social connections are important to their health. Often seniors resist my invitation for a friendly visitor. What research, data, stats do you feel can be important to educating participants?
Thanks. I'll throw some resources in the chat for you to click and explore. One is Genwell. Genwell is constantly sharing information and resources through their mass media campaign, as well as targeted workshops in senior care homes and schools and workplaces to educate, you know, people about the importance of social connection. I think one of the things that we've never done in Canada or in any country is educate people explicitly about social connection. We know we should do our 30 minutes of exercise. We know we should eat our fruits and vegetables, but we leave it to people to just assume that they'll figure out how important social connection. And unfortunately, many people do. Most of us know that social connection relationships are important. But what happens when you're isolated is you become socially vigilant. And so this is a natural response that you're going to encounter with patients over and over and over again. Because when you've been isolated, you become vigilant and social interactions actually become more difficult, challenging, stressful for you. And therefore you want to withdraw and isolate more. And so people kind of get trapped in these cycles. And so educating them about those responses and those things are something that we have to familiarize ourselves with and then familiarize them with. So we developed over 50 evidence briefs to educate people about the importance and relevance of particular types of social connection. Everything from why should I talk to strangers to how many hours of social connection do you need in a week. These really provide all of the science that you need to educate a patient. Those might not be the best format to right hand off to a patient. We've also developed through our cash.org/care website, which you should visit. We have a couple of videos that are meant to be public service announcements that can eventually hopefully play on TV that just call people and try to wake people up to the importance of this social connection. But we do have a fact sheet as well that highlights some of the various ways that this impacts health, and that's developed more in a user-friendly, accessible. So you can print those fact sheets off and hand them directly to your patients. We also have a calendar of social prescriptions of various things they can do on different days. So trying to think of these ways that we can fill that gap is something really important. But hopefully some of those resources might be something that would help you and your patients. Or if you want to work with us to develop something, don't hesitate to reach out. We're always happy to host and share those resources. And I'm sure the same is true with CISP. I think both organizations are really here to provide that sort of meta support for the implementation of these kind of social interventions.
Thanks so much, Kiffer, and thanks for sharing all the valuable resources. They're so important in this work. This question goes to either or both of you, not directly related to your presentations, but maybe your own expertise and thoughts on this. Relates to nature prescriptions. So what role does nature prescriptions have in social prescribing, and how would you say they're related?
Yeah, I was happy if you have anything. I don't want to just be the only one to take space, but yeah, I think it's a lot of this is how it's done, right? Is a lot of these nature prescribing programs that I've seen, it's one visit to a park or half price discount to the zoo. That's probably not a long-term solution for anyone. It might be a way for them to expose and challenge some of their prior beliefs about whether or not they're capable to be out in nature or those sorts of things. So they're not completely useless, but I think people need to develop habits around being outside. And so really they need the community and social supports needed to facilitate those opportunities. And so I think that's what social prescribing aims to help people develop around. And we know that nature time is really beneficial. So.
Yeah, absolutely. And I would emphasize too the importance of the connector role here. To Kiffer's point, like a lot of these things, or the role that nature can play, it really depends on behavior change, and the connector role plays such an important part in helping to foster that behavior change and supporting individuals and managing their own care and building that confidence and motivation to make that one visit more of a habitual thing. And of course it certainly depends on where you are and if you have access to those spaces. But I would say that it's largely to do with behavior change, which the connector role is so important for supporting at the individual level.
Thanks to you both. Kiffer, back to you. First off, the person who asked the question says, great presentation, Kiffer. But ask you to elaborate a bit more on the role of 811 in the social prescribing pathway. Is it used for getting information on existing social support services?
Yeah, so 211 and other kind of directories that exist out there are they're each provincially managed, and so that's one of the big challenges, is that like which version you're accessing varies geographically. But these sort of directories have various levels of depth of information about the programs, and they're presented in various ways. I think the 211 organizations that I've spoke with, a lot of them are affiliated, of course, but the 211 organizations that I've spoken with all have grand plans for how they can make those directories more usable within the context of social prescribing, including the utilization of things like artificial intelligence to link people to the right services, really making sure that they've tagged those databases well. And so they can be used. I think right now, this is just my opinion, and my opinion largely based on our 211 here, is that it's a resource for a community navigator to identify some potential candidate social prescriptions. But as a referral direct to patients, it's probably a little bit too overwhelming to see all of the opportunities. I think one of the challenges of a social prescriber is to kind of work with patients to identify what would be a good fit for you and how do we get there. And I think some of the training materials that Safiya mentioned probably address some of that, and certainly the United Way's programs do.
Thanks, Kiffer. A question that's just come in, and I just want to say, for those of you that are posting questions, if your question does not get answered here, we will go ahead and we'll copy them all down. We'll try and answer the best that we can, and Kiffer and Safiya, we might bring you in to sort of do that sort of response to the questions after the fact. One question for both of you. Can you speak to the experiences you found when interviewing connectors? Do they find themselves be working as more of a referral worker, so less time spent with a senior or other person that they're supporting? Do they find themselves to take on more of a case planner role, so more time spent with each individual person?
Yeah, I can jump in first here. I think I have experienced both, though I would say more often than not, the connectors that I've spoken to do take on a bit more of an in-depth role. And that's not to say that of course, there are boundaries to the role. And I think that's a really important part of supporting the connector, is helping them understand sort of where their the boundaries of how they are able to support. But across the board, I would say that a big part of the role is sort of that deep understanding of an individual's needs. So I think that the relationship building does require a certain level of time spent. And I think we would define social prescribing in its most fulsome way as involving that deep relationship building, holistic needs assessment between the connector and the individual, as a way of understanding what the person's needs are, as well as their desires, their strengths, what their own goals are for their health and well-being. So I would say that when we think about social prescribing in its truest sense, it does involve that time spent, to put it in those words, with the individual.
Yeah, maybe just speak to the variation. There's so much variation across social prescribing programs. I think, and mine's my own ideal, I have an ideal for what I think social prescribing should look for, but my idea isn't going to work everywhere. But I think having something like 250 to 400 patients per year in a workload, something like 6 to 12 sessions per patient, with the more complex patients requiring more sessions, like that is the sort of individualized care that I imagine when I talk about social prescribing. But it looks very different in different places. And I think it's up to the community navigators to really decide what their individual patient might need, what their health system can support. But I think that the sort of training programs that are emerging are helping creating a consensus around what social prescribing is, and helping create some frameworks for implementing, the standards of care, what we think the standard should be. And I think, I wouldn't be surprised if one day if we had a union of social workers that create its own college, that creates some of those own internal standards for what that sort of case management looks like. That's certainly, I think, part of what social prescribing could be or could evolve into. Right now, there's just so much heterogeneity that I think it is almost kind of a beauty. It's kind of like the social prescribing opportunity sometimes is what you make it to be. And so it's up to you to really think about, what does my community need and what role can I play to make a meaningful difference there? And I think while you've got that flexibility, we should all work to explore that flexibility and figure out what is really going to work and what sort of adaptation is needed for different local contexts.
Thank you both. This question I find interesting, it comes around, the terminology in and of itself, and finding that often seniors, elders, they struggle with the concept or the term in itself, social prescribing. Maybe just a few words on how to sort of get around what that actually means and how we might communicate that a little bit better.
Yeah, no, this is definitely something that I think we in the network have, been talking about for many years. That I think that the tricky part of that word prescribing and sort of the medical connotations, but I think getting around that is really focusing on the social aspect. So social in terms of connection and emotional well-being, but also social in terms of your, basic needs, your social welfare. And so I think communicating that social prescribing is, about taking your health out of just the view of physical health care, and helping folks understand that this model of care, of integrating health and social care, is a way to connect folks to all of the amazing things in their neighborhoods, in their communities, that can support their health and well-being. And so I think maybe focusing on the social aspect is an important part. But no, I know that this is something that I think, since I've learned about social prescribing, has been in the conversation. So Kiffer, I'm curious to hear your thoughts.
Yeah, I mean, my thing is, I think it's something we should use in the sector. I think there's utility in us kind of glomming on to this framework as a framework for implementation, particularly as it allows some flexibility for local context, because I think policymakers don't necessarily understand the importance of it yet. And I think what's going to change that is a real systematized approach. So I think we as a sector should use the term social prescribing. But that doesn't mean you have to use it when you're talking to patients, right? Who wants to be involved in a program or a pathway to getting social supports? I mean, that's not exactly the best feeling anyways. Is what people want is they want to feel like a healthcare provider cares about them, connects them. Hey, I've got this person on my team who will help you get connected, and that they're nice. And really, it's that relational experience that's going to matter most to people. So you don't have to use the terminology. I'll say that the reason that I think the terminology came about is because social doctors in particular are the most, even as late as the 2024 Ipsos polling, they're the most trusted professional in our society. We're really leveraging them to help people understand the importance of these social connections to the health. People don't know that loneliness and social isolation is equivalent to smoking 15 cigarettes a day. They know cigarettes are deadly. It's the #1 preventable cause of death, but they don't know that social connections are. And so we're hoping to leverage doctors and their authority and their expertise. So I think that's a rhetorical, but it's more of a marketing strategy, right? You don't have to use that. That's more of like how we change the system. It's not necessarily how we're going to make a patient change. So if the term doesn't work for your patients, call it something else, or just call it by the name of the person who's doing the link worker. Here, let me connect you to Sally. She knows this community so well. She knows all the organizations that you could get connected to, and they don't have to know that it's called social prescribing.
Love that advice, Kiffer. Thanks. How might we leverage the collective knowledge to empower individuals and family caregiver supporters in the community? Example, to enable them to manage all of the overwhelming information and tools as related to their particular needs and share with family and other social connections to spread best practices. Additionally, to support the connector, navigator, link workers to reduce burnout and reach further in the community of practice. That was a mouthful. So how can we, and from your advice, leverage collective knowledge to empower those individuals in community, whether they be family members or the individuals themselves, to do some of this work?
And I think it starts with understanding those social determinants of health, all of the 80% of factors that impact our health that are, nothing to do with our biology or our genetics. I really think it starts there, helping people to understand in whatever language that is most accessible, that where we work, where we live, where we play, where we interact with our communities, that is what impacts our health. So I think starting there is a great point, and it will really get family members, communities on board with the idea of, if I connect with this particular resource or this particular group, it might improve my mental health, or there are pathways that are available to me. I just need support in navigating them. And so I think that fundamental understanding of the broad determinants of health is a great starting point.
Yeah, I don't have a lot more to add. I just say as a model, I really like communities of practice, getting the people who are doing this day in and day out. Like that's, I think, of a way of collective organizing that is really useful, because, it really brings, I try to, even though I'm not a navigator myself, I try to participate or lead these communities because I, as an academic, can bring certain resources and supports. And so I think the best way to have collective impact on this is to get part of a collective, find a group of people who are as interested in it as you are, and see what you can do. And oftentimes it'll coordinate and line up with something a larger organization is doing or another organization is doing, so you can just latch onto them. Or if you're doing something side by side, then I think that's great too. I think there's a lot of people in the social prescribing sector that are all doing similar streams of work. And sometimes that means there's replication, but we try to, even like this example, we try to connect across organizations so that we don't duplicate, or so that we can at least amplify each other's efforts rather than duplicate them. And so I think that's a good one, is kind of get involved. That's not easy for everyone, depending on your times and capacities, but I know the United Way, for its link workers, hosts a community practice and provides time and space for those discussions to take place. So these sort of formalized structures are really helpful for that reason, for sure.
Great, thank you both. Well, I'm going to keep us on time. So with that, I am just going to give us some closing remarks here. All right, so first of all, I just want to say that today's session is part of a 4-part series, exploring the benefits of social prescribing. Today's session was co-organized by United Way BC and the Canadian Alliance for Social Connection and Health, which is an interinstitutional community academic alliance of researchers and practitioners committed to addressing loneliness and social isolation. We're so grateful for this valued partnership and from hearing from their scientific director in Kiffer today. The second session of this 4-part series will take place April 28th, and the topic is leveraging partnerships and networks in social prescribing. So stay tuned for further information on that. And I think actually Laura might be putting the registration link for that in the chat. So as we come to an end of today's social prescribing session, the social prescribing celebration day session, I want to take a moment to thank all of you for joining us and being part of this important conversation. Today, we've explored how social prescribing is transforming the work that we do in community and the power of the community connection, well-being, and support beyond just the medical model. From the inspiring presentations, thank you again, Safiya and Kiffer, shared by our speakers, to the insightful discussion, and thank you all for the engagement and your great questions. We're really looking towards the great future of social prescribing. We hope that today you leave with new ideas, a renewed sense of purpose in supporting these meaningful connections in your own communities. I'd like to extend a heartfelt thank you for all of you joining us today, the expertise and passion that really truly enriched events like this. And of course, really wanting to leave you today with just a couple of thoughts that things like, for me, social prescribing is not just about the individual. It's also about fostering stronger, more resilient communities. It's about creating opportunities for people to find connection, purpose, and support. We're all part of this collective effort to build healthier, more connected lives. So thank you again for being here. Thank you for your time. Thank you for your commitment to this movement. We hope to see you at the rest of the series. Remember to register for that coming up. The title of that is Leveraging Partnerships and Networks in Social Prescribing. Take care, stay connected, and keep making a difference in the lives of others. We wish you all have a wonderful day. Thank you.
Thanks all.